and welcome to Riverside Talk. My name is Denise Mananis. I'm the Associate Vice President of External Affairs at St. John's Riverside Hospital. Today, we are excited to visit the Bronxville Senior Center at the Reformed Church of Bronxville to speak with a urologist, Dr. Mathew Fakhoury, about incontinence, which is experienced by over 25 million Americans, but most people don't really talk about it. So before we get started, however, I would like to acknowledge the team who make these programs possible. That would be Nancy Anabi, our community liaison, Candace Cousins-Hopkins, our Associate Director of External Affairs, Olivia Hunter, another Associate Director of External Affairs, and Jason Latore, our media production manager, who I very affectionately refer to as a wizard. Because he makes all this happen. So let me introduce Dr. Fakhoury. Today, Dr. Mathew Fakhoury is a urologist with Advanced Urology Centers of New York. He completed his Doctor of Osteopathic Medicine degree at New York College of Osteopathic Medicine and a urological surgical residency at Cook County Health and Hospital System in Chicago, Illinois. In 2020, he won the LUGPA Resident Clinical Innovation Award and has published extensively in the urologic literature. He is a member of the AUA, Sexual Medicine Society of North America, the Society of Urologic Prosthetic Surgeons. Dr. Fakhoury specializes in urinary dysfunction, benign prostatic hyperplasia, kidney stones, and sexual dysfunction. So, Dr. Fakhoury, thank you so much for agreeing to do this with us again today.
It's absolutely my pleasure to be here, Denise. I just wanted to voice once again our appreciation to the entire team for making us come together and learn a little bit more about some topics that are sensitive to all of us here in this room. And I think it's really important that we shed some light on these topics because you're not alone.
I love that. Okay, so we're going to just dive right in. Let's talk about incontinence. What causes incontinence?
So there are different flavors of incontinence, as I tell my patients.
Okay.
And that goes along for both men and women. The most common reason that we see incontinence in females has a lot to do with patients that may have had a vaginal delivery in the past. And unfortunately, the pelvic floor isn't really functioning the way that God intended it to. And that's because of a laxity of the muscles. And what happens is the urethra may become a little weak, and as a result of that, the urinary function of the urethra and the sphincter isn't working the way that we need it to, and urine becomes released with less control over our bladder.
Okay. So you equated it to the experience of childbirth.
Childbirth is one of the reasons. That's
right.
Correct.
However, what are some of the
Beyond that, what happens sometimes is, unfortunately, we get into a habit, both men and women get into a habit of holding on to our urine for longer than the bladder would like. And we're all guilty of that.
Yes, we are.
And we probably can remember our parents telling us, go to the bathroom before you get in the car, go to the bathroom before we go on a trip, and we kind of just say, yeah, I'll be fine. And unfortunately, that sticks with us. And as a result of that, the bladder just becomes overwhelmed and tired of holding on to urine for too long. And when that happens, I call it the snowball effect. And what I mean by that, it only takes a couple ounces of urine for there to be leakage. And when the bladder becomes irritated enough, that can occur.
Okay.
So we have to get into the habit of making sure that we're consistently and adequately emptying our bladder each and every day.
Okay, so that's an everybody thing. Everybody holds.
Everybody.
What about disease-specific as a consequence?
Sure. So with respect to surgical interventions that patients may have, the urethra and the sphincter may be affected, and those become a little more complex in treatment because it may require some reconstructive surgery, for instance. Now, with respect to prostate cancer treatment strictly for men, one of the side effects that we end up dealing with is stress incontinence and urgency incontinence, depending on the therapy that's chosen for the prostate cancer treatment, whether it be radiation therapy or removal or radical prostatectomy of the prostate.
Okay, what's the difference between stress incontinence and urgency?
So those are the two flavors of urgent.
I love how you say flavors.
It's got to be simple enough. It's taking something complicated and is not very easy for patients to talk about and making it simple brings a lot more enjoyment in the conversation,
Yeah,
and
no,
knowing that
I
there's a
think it's great.
pathway, there's a journey, and
Yeah.
our final destination is for you to be better. So the two flavors that I
Yeah.
talk about are stress incontinence and urgency incontinence. I must have had this conversation 5 times today, earlier in the morning with patients. And urgency incontinence is essentially when you get the urge to go to the bathroom and it hits you like lightning and you're looking around, where's the closest bathroom? Because I need it right now.
Okay.
And that's when the bladder tells your brain, get to the bathroom immediately or I'm going to let this go. Okay. And that's urgency urinary incontinence. Stress incontinence is a little different. That flavor incontinence comes when patients may cough, sneeze, laugh, jump up and down, exercise, and they'll feel a little tinkle. And that's called stress incontinence, where, again, the pelvic floor isn't providing the support to the urethra, which is the channel that allows urine to exit the bladder into the outside world.
Okay. So, I mean, I'm listening to you talk and I'm thinking of everyone I know and everyone of my mother's age and they have both of those.
Right.
So you can have both of those simultaneously.
That is called mixed urinary incontinence. Yes, you can.
Okay. All right. So let's go back to the holding of the urine. Is there an opportunity that you have to actually retrain the bladder?
I love that you said that.
Okay.
Okay.
I love that.
Love
He loves that.
Yeah.
Okay.
So I spend a lot of time talking about bladder training. And a lot of urologists don't because it takes quite a bit of time to explain.
Interesting.
So I call it the rule of twos. Okay? Dr. Fakhoury's rule of twos. And what I tell my patients, and I have this typed out, and most patients will leave with this little pamphlet before they leave the office, just as a gentle reminder. The rule of twos simply comes down to the following things. 3 simple steps that anybody can do at home to help retrain and refocus the bladder. And on the top of that pamphlet, I have a little quote basically saying, training your bladder to work for you and not the other way around. Okay? And that's what we all want to get down to. So with retraining of the bladder, what we're hoping to do is make sure that we're emptying the bladder adequately and consistently each time that we void. How do we do that? Back to the rule of twos. I tell my patients every 2 to 3 hours, I'd like you to go to the restroom regardless of the sensation to pee. Do not wait for your bladder to tell your brain, go pee. I want you to take control over that. And in sort of an internal alarm clock develops in your brain, just by way of habit, that you go to the bathroom every 2 to 3 hours, especially with teachers and bus drivers and people who are just not constantly around a bathroom whenever they need to. If you have an opportunity and it's been 2 hours, empty your bladder. Okay? Beyond
Even
that.
if you don't feel
Right.
need.
For patients that come to me with urinary complaints, whether it be urinary retention, urgency, frequency, incontinence, it's important that these patients are emptying the bladder adequately and consistently. Because to boil it down to something very simple, if there's no urine in the bladder, there's no urine to leak. So we want to get rid of the urine in a more controlled fashion. So rule of twos, every 2 to 3 hours, go ahead and void. Second point, when you get to the restroom, for both men and women, obviously you sit down on the toilet, you urinate, and you feel like you've completely emptied your bladder. I tell them to stand up, give me a little shake for 10 seconds, stomp your feet in place for 10 seconds. It's embarrassing, but it's very helpful. And what that does is it essentially tricks your bladder into thinking, I gotta pee again. And all of a sudden you sit back down and you're like, oh my gosh, there's more coming out. I guess I wasn't done. Okay?
So really it's the misuse of, or the abuse of our bladder over time, just the idea that we've held it all that time.
Correct.
And so now how long does retraining?
I call it payback.
Oh,
It's bladder
it is.
payback.
Oh, it is. Yeah. How long does that take?
The retraining of the bladder?
Yeah.
Everybody's a little different.
Okay.
So when I have this discussion with my patients, I make sure that they're trying to consistently do it for at least 6 weeks, and it can take up to 3 months for patients to see a difference. Let me go back to the bladder training. The third point of that is less fluids 2 hours prior to bedtime.
Okay, that's
a
really
big one.
important.
Because
Less
fluids 2 hours before bedtime.
So when you say less, do you mean none?
I don't want to say none because patients have to take medications. Okay, and usually what the patients will tell me is, well, my doctor said I should drink as much as I possibly can all day, all night. And I disagree with that sentiment. Okay, what happens is if we drink close to bedtime, a significant amount of fluid, your kidneys are going to make the urine. The urine's going to be stored in your bladder through the night. Two options here. You either wake up and go to the bathroom, destroy your sleep pattern, or you tell yourself, you know what, I'm kind of tired, I'll just do it in the morning. By that time, the urine's been in your bladder for 5, 6, 8 hours. So when you wake up in the morning and you're running to get to that restroom, your bladder is basically telling you, why'd you do this to me? Okay?
Oh,
Yep.
an angry bladder.
Angry bladder.
So.
That's right.
Yeah, we don't want that.
No.
Okay. So let's go back for a second. We talked about causes in men, causes in women. I do think it's more prevalent in women. Is that a fair statement?
It's a fair statement. And I think a lot of that has to do with the fact that it's such a sensitive topic for men, and I think it's underdiagnosed in men.
Okay.
And I do think, obviously, for more than one reason, women do suffer from incontinence a bit more, and a lot of that has to do with just anatomy and physiology.
And childbirth.
And childbirth, and the fact that the urethra is much shorter in a female than it is compared to a man. And for the men that are listening to this and are trying to get some information, the prostate is also a big reason for why you may not have that leaking, because there's an obstruction of urinary flow from the bladder to the outside world. But when that obstruction gets really bad, eventually your bladder says, I can't hold on to the urine any longer, and you develop overflow incontinence.
Oh, a whole new kind.
A whole new kind.
A whole new
More likely in men.
Okay. All right. I got that. All right. So retraining the bladder is one remedy,
Right.
and it varies for everybody. Are there other remedies, things people can do aside from the retraining? You talked about not drinking 2 hours before bed. That's part of the retraining. But are there remedies? Are there exercises?
So I don't want to undersell the bladder training, because I give patients an option of starting them on a medication, a daily tablet by mouth, to help with urgency incontinence.
What is that medication?
There are some medications. The older medications that are more commonly seen are anticholinergics. And unfortunately, there are several receptors in our body that have these anticholinergic medications in mind. And because of that, there are undesired side effects: urinary retention, dry eyes, dry mouth, and most recently a study was published showing the increased risk of dementia and Alzheimer's in these patients who've been on these medications for so long. So urologists are moving away from the anticholinergic remedies.
So how do those work? They dry up?
Essentially what they do. Yeah, exactly. And what they're basically telling the bladder is stop squeezing. Okay. But there are newer medications on the market now that are much cleaner, and they have one desired effect, which is tell the bladder to relax. And I call it the chill pill for the bladder. Okay. It literally tells the bladder, don't squeeze until it's necessary to squeeze. So that's a remedy, but the reason why I bring it up is patients will come in 3 months later after hearing about the bladder training and say, Doc, you know what? I forgot all about the medicine you gave me, and the bladder training has been working great for me.
Okay.
Yeah.
All right. So, but so are there varying degrees of incontinence? Like some people, it's just,
Absolutely.
and other people.
And that's a mental gauge that I have for myself when discussing with the patient.
Okay.
For instance, how many pads a day do you have to use? Are you using Depends or pull-ups or diapers or panty liners? Unfortunately, that can change how aggressive I am with my therapy. And it's really what it boils down to is quality of life.
Right.
How much is this affecting your quality of life? Is it affecting your time with your grandchildren? If the answer is yes, then I'm doing everything I possibly can to fix that.
So is this a diagnosis more in the older population?
It is.
So you don't see this in women in their 30s, 40s, 50s, or you can?
I do. And for those women and men that I see this symptom in, or this urological complaint, are teachers, bus drivers, cab drivers, guys
they're
and girls who cannot get to the restroom when they desire to, especially with teachers. It's very common with the younger, in their 30s or 40s. Teachers have a very hard time of getting to the restroom when they need to, so they train their bladders to hold it. And they'll come in and they'll tell me, Doc, yeah, I mean, you're going to be proud of me. I didn't pee for 5 hours. And I'll tell them, no, that's not what we want. We don't want that. Eventually it catches up to you.
All right. So you talked about a medicine that you can do. Are there surgical or procedural interventions?
There are.
Okay.
Before we get to that, Denise,
Yeah.
I have this wonderful cup of coffee that somebody poured for me. This is a really bad bladder irritant.
Oh, coffee.
So
That's too bad.
the four big things we talk about for bladder irritants are coffee, caffeine, tea, carbonated beverages, spicy foods. Now, there's no way I'm going to tell somebody don't have any of those things because I can't do that myself. But just minimize it. If you come in with these complaints to the urology office, just know you're going to have a conversation about avoiding bladder irritants. If you have 3 cups of coffee a day, let's bring it down to 2 cups. Let's switch to decaf.
So, but even chocolate and even other kinds of drinks have caffeine.
Caffeine, but less so.
Okay.
Less so.
I can't give up the chocolate.
No, I would,
We have
God
to talk
forbid.
about that.
God forbid,
Okay.
yeah.
All right.
So surgical
Yeah,
interventions.
or procedural interventions.
We've made some tremendous advancements in how we can treat incontinence. Now, urgency incontinence isn't really treated with surgical interventions most times unless we've tried everything in our armamentarium. Then we may suggest something like a Botox injection or nerve stimulation. Outside,
But wait. So a Botox
Botox.
injection.
I
So-
knew that would catch
Yeah,
attention.
no, I got you. So how does that work?
So, for most of us, we think of Botox in the aesthetic world, right, to get rid of the wrinkles and things like that. But take that concept and apply it to the bladder. And what we do with Botox injections is usually under anesthesia, but a lot of times we don't need anesthesia. It's done locally in our office, and it takes about 2 minutes. And what we're doing is injecting Botox into the bladder at about 10 to 15 different locations.
Oh, into the bladder.
Into the bladder. And what it does is it kind of freezes the bladder a little bit, similar to what we would use it for in our face.
Okay.
Yep.
Now, is there another, like I've heard of collagen being used
Right.
so can you talk a little bit about that? Is that something you don't do anymore?
Separate from urgency incontinence, it's not really an indication, something that we do.
Okay.
Yeah.
All right.
But surgically, to your point about stress incontinence, with stress incontinence, we do have an opportunity to give therapy surgically, okay? Now, one of the most common things that we hear about is sling placement or a mesh urinary sling placement for the urethra. Now, there's a lot around the slings themselves because of the mesh, and there's FDA warnings and things of that nature. So for patients that want to stay away from that kind of surgical intervention, what we talk about is injection therapy with a water-based gel, okay? And this literally takes us 1 single minute in the hospital, usually done under a very light sedation, and it takes me literally a minute to complete this. It's called Bulkamid, okay? And what we're doing with that is it's a water-based gel that gets injected into the urethra. So basically, in real time, what the urethra looks like is this
a
before,
tube.
and afterwards, it's this.
Oh, so it's able to hold.
We're giving it the support it once had, we're giving it back.
Oh, and
Okay.
what is that stuff
It's,
they
it's,
put in?
it's a water-based gel. It's literally an injection system that we put into the urethra in 4 different locations, and patients get up and walk out of the hospital.
How long does that last?
For some patients, it could last 6 months or more.
Okay.
Okay.
And the Botox in the bladder?
Same kind of deal.
Same kind of thing. Okay. Very interesting. All right, so those are sort of medicinal and surgical. What about natural remedies?
So the big natural remedies are retraining the bladder.
Okay.
Okay. Avoiding those bladder irritants, Kegel exercises for stress incontinence. We hear a lot about Kegel exercises. It's essentially a way for us to practice building up the tension in the pelvic floor in a controlled fashion. And you can do that all day, every day. Basically sitting down watching TV.
But do people?
No, they don't. It's a difficult thing for someone to tell themselves, I have to do this 50 times a day.
Yes.
Especially for men, because men can benefit from it after removal of their prostate gland, but convincing a man to do that may not be so easy.
Okay. All right, so that's very interesting. All right, so now let's go to another possible cause of incontinence. Can certain medications that people are on for other things cause an incontinence situation?
Great question. So one of the things we're going to talk about it in a more general, broad term is diabetes. Okay. The effect of diabetes on urinary flow and incontinence is very, very strong. And one of the first things we talk about in patients with uncontrolled diabetes or an elevated hemoglobin A1C is the effect of the diabetes and sugar in the urine on the bladder function and the urethra function. The bladder does not like sugar. And unfortunately, the nerves of the bladder, you can end up developing something called the diabetic cystopathy, which is basically where your bladder is numb and it's just not feeling the sensation of having to urinate. When it comes to medications as a side effect causing urinary incontinence, it's quite uncommon.
Okay.
But the opposite is very common. For medications to cause urinary retention and patients eventually developing liters of urine in their bladder, and that unfortunately can make its way out as a result of the bladder just not being able to hold that valve.
Wow. Okay. So there's been in the news recently some articles on a new minimally invasive incontinence device. Are you familiar?
Which one?
I'm not really sure what it's called.
So one of the things I touched up on very briefly was nerve stimulation. That's considered, yeah, that's considered a minimally invasive
So is
procedure.
that like an implantable?
Exactly.
Okay, because they do that for other sorts of pain.
That's right.
In
It's
other places?
interventional for pain control. And the device itself basically acts as the brain of the bladder. And it's something that's done in the hospital, usually requiring 2 stages. And what we're doing is we're testing a certain nerve root, the S3 nerve root, and checking to see whether or not if we manipulate that nerve, does it allow for alleviation of some of those symptoms.
Okay.
But it does require a 2-stage procedure.
So who qualifies for things like that?
So fortunately and unfortunately, there is an algorithm involved in these things. So we have to follow our guidelines, and there are guidelines for specific urgency or stress incontinence developed by the American Urologic Association that we follow to the best of our ability, albeit some patients, it's just difficult to follow certain guidelines. We have to go through those guidelines of bladder training, behavioral therapies and remedies, as we discussed earlier, medications, Botox, and if those patients fail those things, then they have the opportunity to explore the next option, which may be something such as a nerve stimulator.
Okay, well, that's really interesting because we do a lot of stuff with the back and back pain and chronic pain and
the nerves that
those
control
kinds of implantables.
the nerves that control our urination stem from our spinal cord. So, spinal cord injury patients, that's another point that we didn't bring up, or I didn't bring up. Spinal cord injury patients can have really bad urinary incontinence that tremendously affects their quality of life.
Right. So we've talked a lot about different treatments and things, but you're gonna, I want the magic pill.
Right.
The cure. So there's really no cure.
There is a cure.
Okay.
And I think that every patient that comes and sees either myself or some of my partners, the cure is different for a little bit. It's different for everybody else. But the one thing that works for absolutely everybody, it's the retraining of the bladder. It's really focusing on getting the urine out in a controlled fashion. There is nobody that won't work for or won't help.
So does exercise in general help? I know you said Kegel exercises. That's a hard one for people to sort of incorporate into their mindset.
Right.
But is that something general physical activity help with it?
In the world of urology, anything that is good for your heart is good for the components of our field.
Okay. All right. So let's sort of, before we go and turn to the audience for any questions,
Sure.
Do you have any general advice for people who are dealing with incontinence?
You are not alone. You are not alone, both men and women included. We have therapies that work and work well, and they won't cause a change in the way that you live your lifestyle. Our goals are unanimously on the same platform. We want to deliver and restore your quality of life. And it just takes you coming in to see us in the office. That's all it is. Talk to your primary care physician. Have them send you to a urologist in your area to discuss this, and you won't regret it.
Okay. All right. So now let's take a turn to our audience. Hello, everybody.
Oh, that's nice.
Hi.
Hello.
So anybody out here have a question for Dr. Fakhoury?
And not why are you consuming a bladder irritant right now.
Yeah. Yes, ma'am.
On kidney stones, if you've had one, are you likely to develop other stones?
Great question, Mary. So anybody that develops a kidney stone, by default, according to our literature, is at a 50% chance of developing another kidney stone in their lifetime. If changes are not made to dietary modifications, behavioral modifications. Really good question.
That was an interesting thing. You just said dietary. Is there a diet other than the things that you mentioned? You didn't mention alcohol. Is alcohol an irritant?
It is.
And are there other kinds of diets that contribute to the irritation of the bladder that makes this worse?
So alcohol is definitely one of those bladder irritants. I'm sure many of us have had a beer and had to run to the restroom immediately. And that has a lot to do with the alcohol itself, plus the carbonation of the fluid that you're taking in. Anything with carbonation is considered to be a bladder irritant. Wine doesn't have the carbonation, but it does have the fermentation that may result in some type of irritation of the bladder mucosa.
What about, hard liquors like vodka and
Less so.
gin? Okay.
Less so.
All right. A little good news.
Little goodness. Yeah.
All right. Yes. Yeah. So we said hard liquor like gin and vodka. And so this program is actually going to be on all of our social media channels, so you can watch it again if you'd like. Do we have any other questions for the doctor? Yes, ma'am.
I heard that dairy is also a bladder irritant.
So dairy is an interesting topic. What we didn't discuss much, just because of time, is how bowel movements and bowel health affect urination.
Oh.
And what I tell patients is number 2 absolutely affects number 1. And what do I mean by that? Just from a sense of real estate, your colon and your bladder are neighbors. So if anything causes an upset stomach, or for instance, dairy with diarrhea or constipation, these things absolutely affect the way that your bladder functions. With respect, more of a general outline, does dairy affect the bladder irritation the way that the other things do? No. However, if a patient has some type of sensitivity or irritable bowel syndrome, which are very, very common and quite underdiagnosed, then yes, you can see some changes in the way that the bladder functions. Absolutely. Good point.
Wow. Okay. Yes, sir.
There are various medications that act as diuretics, even though they're not intended to serve primary purpose. So is there a way of finding a list of things, or
A list of the meds?
whatever things you're taking, and look them up, see what it says?
There are some actual websites that we use and talk to our patients about that will talk about different medications and their effect on urinary flow. With respect to the diuretics, we have a lot of patients, obviously, that come in and say that, well, I'm on the water pill at night. Of course I use the bathroom at night. And that's not really the problem. The problem is not the medication that you're taking that's causing the extra fluid in your body to be released. It's how your body is releasing that fluid and when it's deciding to do so. So the issue isn't really the water pill or the Lasix or the furosemide. It's how your body is taking that fluid and when it decides to actually get it out of your body.
Okay. And that's why the retraining is so important.
Yeah, you're all probably very sick of hearing about this retraining of the bladder, but I promise you, it helps.
It's the hard work that we have to do. Any
Right.
other questions from our audience? Yes, ma'am.
I'm wondering if you're sensitive to gluten, does that have any impact?
It does. It does, but indirectly. It doesn't directly affect the way that the bladder functions, but as an indirect change of how gluten may change your bowels and your colon and your stomach, for instance, it can affect indirectly the way that the bladder is functioning.
Anybody else? Yes, ma'am.
You were talking about kidney stones.
Yes, ma'am.
Is there a diet, or are there foods that we should avoid? So
For kidney stones?
Yeah, we got to talk about this. This is a great question.
Yeah.
Glad you asked that. So the 3 biggest things that we talk about for kidney stone prevention. Okay, number 1 is the amount of fluid you intake, specifically water. Okay, you want to, for kidney stone formers, okay, who've had a kidney stone in the past, our guidelines tell us we want to be able to produce 2 liters of urine a day. Okay, exactly. All right. So that tells us that we're consuming enough fluid to help wash out all of the byproducts that we take in so that a kidney stone may not develop. And I tell my patients, lemon is your friend. Lemon contains citrate or citric acid, which is a potent inhibitor of kidney stone formation. So taking that lemon, cutting it in half, and squeezing a lemon juice into your water has been proven to reduce the risk of stone formation. Number 2, salt intake. Reduce your salt intake. None of us should be adding salt to our food. And number 3 is red meat intake. I hear somebody laughing. You shouldn't. Red meat intake. Now, that doesn't mean you can't have a burger or a steak every once in a while. That's not what we're saying. You just want to do it in moderation. And if you know you're going to have that for dinner, your bottle of water should be the next thing that you consume to flush these things out of your system.
Very interesting.
Spinach, also not great for kidney stones.
Really?
I knew it.
Spinach?
I knew it. Yeah.
Oh
Yeah.
my God.
So spinach contains a very high level of oxalate, and oxalate is one of the number 1 contributors of stone formation.
So are there people who are prone to kidney stones and people who are not prone to them?
I don't want to get into the weeds about this, but there are certain genetic syndromes and certain dispositions that cause patients to have kidney stones, gastric bypass, Roux-en-Y surgeries. There's quite a few things out there that can increase the risk of developing kidney stones in the future.
Okay.
But those 3 things will work and help towards, for anybody, whether it's a surgical cause or not, to reduce the risk of developing a stone.
Okay. Any other questions? Lemon in the water. Yes, ma'am.
You said decaf is better than regular coffee?
Yes.
You did say that.
With respect to bladder irritation, yes.
But
Less
if,
caffeine.
but if you have 1 cup of coffee in the morning and then
No
you,
big deal.
Okay.
No big deal.
So it's really about moderation in those things too.
Exactly.
Okay. Anybody else? Anybody? No? Okay. Well, before we close, I would like to acknowledge the community partners that help us put this program on. So some of them include the Yonkers Neighborhood Naturally Occurring Retirement Community, the Yonkers Public Library, the Ashling Irish Community and Cultural Center, the Department of Veteran Services, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Greenberg Parks and Rec, Hastings and Irvington Community Centers, Westchester Jewish Community Services, and Yonkers Pathway to Success. And with that, I would like to thank Dr. Fakhoury. Let's give him a round of applause because
Thank
he
you.
is
Thank you
wonderful.
all.
And he's located here as an office here in Bronxville. So check him out. And thank you again. He has an office here in Bronxville.
Just down the road.
Absolutely. Yep, 77.
77 Pondfield Road.
Yep. All right. So thank you all for joining us today.
Thank you all. Thank you, guys.
Thank you very much.
Thank you.